Thank you very much, Dr. Mansour, for the kind introduction. Thank you for organizing committee for inviting me. I know it's the last lecture of a very long 2 days lecture series, so thank you for staying here at this late time. So I promise I'll be faster than the time allotted. So the first disclaimer I would say is titled Challenging Cases in Management. So forgive me, but I won't have much evidence to go on. You will just see an expert thrombosis person, how he thinks and how he extrapolates data from other evidence to manage these challenging cases. So down to the first case. So this is Mr. M. He's a 28-year-old man diagnosed with HIV 4 months ago and started on Biktarvy, which is a 3-drug combination for antiretroviral therapy. He was brought to the emergency room by his brother with decreased level of consciousness, developed seizures and intubated in the ER, was found to be anemic and thrombocytopenic with mild neutropenia. And they did a CBC in his labs, and it showed a white blood cells slightly lower, 4.3, but his platelets were 12. His hemoglobin was 9.3. Retics weren't that elevated. It was 89, so within normal. MCV was normal. INR was 1.2. PTT was normal. It's not mentioned there. LDH was slightly elevated. Our norm is up to 220, so it was 430. Total bilirubin was 58. Indirect bilirubin was 34, so more or less half and half. Haptoglobin was sent. It takes around 2 days to get back in our center. Creatinine was normal. And the blood film showed mild to moderate schistocytosis with no significant polychromasia, I would say. His plasma score was done, and as it shows to you, he came back 7 points actually, so it was high risk. And we were called in to pitch in our opinion regarding TTP in this patient. It was very unclear, was very difficult. I didn't have anybody attending with the patient. And I looked at the peripheral blood film and confirmed what the report was saying, mild to moderate. So it wasn't really jumping at you, but then again, what would have it been? Now, we reviewed his medication, doesn't cause any picture of pancytopenia. Could it be just HIV-related pancytopenia in him? And what we're saying is a red herring. Regardlessly, he was started on treatment for meningitis, although he was afebrile, but he did have seizures in the ER. So suspected for meningitis, started on antibacterial and acyclovir. He was also started by us on plasma exchange and methylprednisolone with caplacizumab, suspecting TTP. A bone marrow biopsy was done on the same day of admission, and it did not reveal any obvious abnormality, actually. So upon follow-up, his cultures remained negative. And just to tell you, we started a bit of evidence here, but since 2021 and even in the recent ISTH updated guidelines for the management of TTP, it's now recommended to start the quadruple therapy. So plasma exchange, steroids, caplacizumab, and rituximab all together. We elected to hold off on rituximab. Rituximab effect really in TTP comes in either in refractory cases to plasma exchange or to decrease the recurrence rate. So we thought we can wait a couple of days until we start it. So without rituximab, after just 3 days of plasma exchange, his platelets started completely normalized. So that was a very rapid jump. From the next day, it came back to more than 80. Third day, it was already more than 150. So we elected to stop the, to start with, we stopped the, he remained intubated and started to drop his, So we discontinued plasma exchange to start with, kept him on caplacizumab, but even with that improvement, we started stopping caplacizumab and slowly stopped the steroids as well. He remained intubated and started to drop his platelets rapidly by day 6 or 7. So again, we initiated everything this time. But this time, he didn't recover his platelet that fast. So we added rituximab on day 4. So after 10 days of quadruple therapy, his platelets normalized and plasma exchange tapered and discontinued after 4 days. Though his platelets dropped, he was clinically well and improving. So even with the platelet drop the second time, it didn't really correlate that much. He was parameters improving, didn't require inotropes, was still intubated. We received his initial ADAM-TS13 level, which came back less than 1%. So it took us around almost 7 to 10 days to get that result. And it was actually 2 samples, so one from the initial presentation and one from the second drop of platelet when we stopped the initial therapy. So he started improving, and we confirmed the diagnosis, tapered off the plasma exchange, tapered off, we sent him on caplacizumab with tapering steroids scheduled over the next 2 months, and we continued his rituximab doses as an outpatient. So we usually give the 375 milligram per meter square, 4 doses weekly for 4 weeks. So rituximab was completed. Hemolytic parameters became near normal. This was almost 5 weeks since his presentation. And Adam TS13 was sent again just to see the response for him. It came back 0.4%. And this didn't make any sense to me because actually he was sitting, coming to the clinic, completely normal, but the Adam TS13 was 0.4%. Platelets were like 200 or something, so it was completely normalized. Parameters, hemolytic parameters were just barely above normal. So what do you do then? And that was really challenging. He's doing very well, but the Adam TS13 is 0.4. So what I decided was basically continue the same for the time being, stop steroid tapering, keep him on the same dose until I figure out what's the next step in his management. So 2 weeks later, he comes back with completely normal CBC, completely normal hemolytic parameters, and we send an Adam TS13, and suddenly it's 39%. So at this point, we stopped caplacizumab, we continued tapering of steroids, and he is now off steroids for more than 3 weeks with complete lab works. So why was there delay in Adam TS13 response? So first 2 samples were done using Fred's VWF73 assay. It was sent outside to Biosentia. The follow-up samples were done using Hemocell AccuStar assay. Again, we don't have it in our center, so it was sent to another center in Riyadh. And the FRET uses the von Willebrand factor 73, which is a 73 amino acid residue as a minimal substrate for MTS13, whereas the Hemocell AccuStar, it's a very rapid test. So it's done, just you load the cartridge and it's done immediately. It's high sensitivity and based on a chemiluminescent immunoassay offering clinicians rapid on-demand MTS13 activity. I honestly didn't know about these differences from before. So those were the differences. And when you look at the literature, so the gold standard for measuring ADAM-TS13 activity is the FRET method. So here they did a comparison of different immunoassays versus the gold standard, and what they found was that although the concordance between the FRET's testing and the other method was generally very good, discrepancies were found in a small number tested on AccuStar affecting diagnosis, 5 out of 32 samples, and follow-up in 7 out of 51. And what happens in the ranges that range between 10 to 20%, the Hemocell AccuStar method tends to underestimate the activity. So you will actually get false positive results, so false low results on that assays. And that's what happened. And Warfarin is actually the company that sells or you can markets the Hemocell AccuStar method, and they have acknowledged that limitation in their testing. So what I learned from this case was actually use your clinical judgment when interpreting the results of Hemocell AccuStar. FRET still remains the gold standard, and definitely probably you will need to confirm low levels with FRET. If you get high levels with the AccuStar, then that's sufficient enough. You don't need to go further. But that was a learning point for me. So we'll go to the second case. So this is Miss W. She was a 14-year-old girl, woke at home with right leg pain and swelling suddenly. No trauma, nothing provoked that. She came to the emergency room and was diagnosed with right common femoral vein and popliteal vein thrombosis. Her mother was diagnosed 10 years ago, before her presentation, with JAK2 positive associated portal vein thrombosis. She was diagnosed with, so the girl was diagnosed with an unprovoked right proximal DVT. CBC, renal function, LFTs were all normal. So the question that comes to everybody's mind, should she be tested for thrombophilia? Which anticoagulant should you start? And how long would you treat the patient? So definitely, she's a young patient. She has a family history, and we do have certain families with familial JAK2 mutation. So we did send full thrombophilia screening for her protein S, protein C, antithrombin, factor V Leiden, prothrombin G mutation, lupus anticoagulant beta-2 glycoprotein antibodies and anticardiolipin, JAK2 and PNH, and all came back negative. I brought in the red-colored antithrombin-resistant factor 2 mutation. We don't usually send for that. I don't know if anybody in the audience or in the panel sends for that, but we don't send for it. Anyhow, choice of anticoagulant acutely managing the patient. I usually tend to treat the patients with low molecular weight heparin when they're extremely symptomatic. The anti-inflammatory effect in low molecular weight heparin does improve symptoms quite rapidly in these patients. And she was 14 years old. This was 4 years ago, so the data was just coming up for use of DOACs in pediatric patients, which I have to say since 2021, rivaroxaban and apixaban have been approved for use in pediatric patients. Duration initially was decided for 3 to 6 months. So pediatric patients usually are treated for 3 to 6 months. They don't believe that much in a long extended duration, not like us in adults. So all thrombophilia screening was sent and turned negative. JAK2 was negative. Low molecular started. What to do next? And there was something fishy in the patient. Why would a 14-year-old wake up with a proximal leg DVT? So we ended up sending for her whole exome sequencing. And this is what we got. So she has a homozygous mutation in factor 5 gene on Bayesian computed analysis, likely pathogenic and may lead to thrombosis, not previously described in their library of mutations. Her parents were screened for the mutation and turned out to be positive, both heterozygous, and they are in a consanguineous marriage. So here we actually found a new mutation in factor 5, which probably behaves like a factor 5 laden. So initially, we treated her with low molecular weight heparin. After 4 weeks, we switched her to apixaban 5 milligram BID. Now, with the information of the whole exome sequencing, what should we do after 6 months of therapy? Should we decrease it to 2.5? Should we switch to warfarin or stop anticoagulation? So going back 12 years, so Amplify Extend or Einstein Choice, so these were the trials for the extended duration of DOACs initially, which showed that dropping the dose of to prophylactic doses was sufficient enough. It didn't cause more increased thrombosis. But one thing in them was they were never compared to the higher dose. For example, rivaroxaban was compared to aspirin, lower dose or higher dose to aspirin, but not to each other. Apixaban was also the full dose or prophylactic dose was compared to placebo, but not to each other. So you don't really know what would have been the outcome if we compared both of them. So the RENOVE trial, which was recently published in March 2025, they did this trial to answer this question. What's interesting in this trial, they actually did include patients with thrombophilia, high-risk thrombophilia and low-risk thrombophilia. So you needed basically patients with a VTE high risk of recurrence who would require extended anticoagulation. And it was exactly half of the patient got prophylactic dose, around 1,400 patients, and 1,400 patients got full therapeutic dose extended to see if there was decreased risk of thrombosis. It was a non-inferiority trial. So in regards to thrombosis, the reduced dose had a recurrence risk of 2.2, while the full dose has 1.8%, and it did not reach the cut limit for non-inferiority. Whereas the bleeding risk, again, was bleeding risk was actually lower in the reduced dose compared to the full dose. So the conclusion was in patients with venous thromboembolism requiring extended anticoagulation, reduction of the direct oral anticoagulant dose did not meet the non-inferiority criteria. But on the other hand, it was an event-driven trial, so number of events were very, very small to draw that full conclusion on that. But nonetheless, the lower dose did show significant reduction in the bleeding risk. So how I interpret this with the previous Einstein Extend or the Amplify Extend and the Einstein Choice, what I usually do in the high-risk thrombophilia, which we know those are the homozygous, I understand that this mutation has not been reported. I usually tend in high-risk thrombophilia, keeping them on 5 milligram twice daily apixaban or rivaroxaban full dose, not dropping them to prophylaxis. It's just we don't have enough data to tell us that would be sufficient for high risk. So for high risk thrombophilia on extended anticoagulation, I would just continue on the full dose, only consider dropping into prophylaxis if they bleed on it. So she is maintained on apixaban 5 milligram BID for the last 14 years. She's starting university this year, and there hasn't been any recurrence till now, alhamdulillah. So use of advanced modalities for testing, that was very beneficial for us in diagnosing these patients. DOACs are the standard of care, but one size may not fit all. And caution in high-risk thrombophilia, as I described to you guys. So third case. So this is Mrs. N. She's 30-year-old female, PAR-1 plus 0. She was referred to us for elevated platelets. So she gave birth 2 years ago, and a healthy baby. We reviewed her labs in our institution, and it reveals a high platelet count for the last 3 years. That's the duration she has been registered in our institution. It ranges from 500 to 600. There was no relevant family history. She didn't have any iron deficiency anemia, no ongoing infection to explain this elevated platelet count. So we sent for her in-house JAK2 mutation, which turns back to be negative. We did send a next-generation sequencing MPN panel, which includes MPL and CAR-R, which were negative, plus 8 other mutations. Whole exome sequencing was sent for her, and it revealed MPL mutation, Pro106 LEU. And Dr. Musa is here, who's an expert. I would say his paper will be referenced in the next few slides. So she came in to review the results of the whole exome sequencing and informed us that she is pregnant, 5 weeks of gestation. So how would you manage this patient now with all of these findings? So does she require cytoreductive therapy? She's pregnant now. What about aspirin, starting when, until when? And what about prophylactic anticoagulation? All those questions came up, and you have to look for the evidence, which you won't find any evidence, to be honest with you. So what I found really helpful is this how I treat paper in the blood journal. And basically, this is the way they treat patients at Guy's and St. Thomas's in London. And for the patients, high risk or low risk, it really depends on their obstetrical history and previous history of thrombosis. In our case, the patient is a low-risk patient, so they would, if the patient had essential thrombocythemia, so not really our mutation, this is familial thrombocytopenia, thrombocytosis. If the patient had essential thrombocythemia, they would only treat her with aspirin low dose, postpartum prophylaxis with low molecular weight heparin, and only in patients who are already started on cytoreductive therapy, they may choose to switch, or they would switch her to interferon and during pregnancy, but otherwise they would not introduce cytoreductive during pregnancy if she was regarded as a low risk for obstetrical complication. And that low risk is defined by the obstetrical follow-up guidelines in UK. So what about the Pro106 LEU mutation? So there has been, I found 2 publications on PubMed search. So the first one is in the British Journal from 2008 of 18 cases. The other one is by Dr. Musa Zahrani and colleagues, which they looked retrospectively at 2 institutions in Riyadh, and they found 115 patients like that. They did a full description on that, but again, I couldn't access the full paper, but there wasn't mentioned any of pregnancy outcomes and that, and it's very hard to find that. So what we decided to do with her was the following. So low-dose aspirin started since the time I've seen her, and postpartum VTE prophylaxis is planned for her once she delivered for 6 weeks duration. So that was our plan for her. Very difficult to find evidence in managing these patients. What I can say about this familial thrombocytosis doesn't behave really like essential thrombocythemias. If you have homozygous mutations, you have a much higher platelet count than if you have a heterozygous mutations. You don't get those staghorn cells on bone marrow biopsies. Fibrosis with a very low incidence in those patients. It's believed they may not be behaving like essential thrombocythemia, but I guess time will tell us in the follow-up studies to those patients. So is associated with familial thrombocytosis, more in Arabs. By the way, those 2 papers, even the one in the British Journal, all are Arab patients. Likely behave differently from ET, but data is lacking to draw full conclusions on that. Last case, I think Dr. Sarah mentioned on that, but this is a 65-year-old man who is diagnosed with gastric cancer. He has received chemotherapy for the last 3 months, so they started chemo just twice to shrink the mass before surgery, neoadjuvant. He was diagnosed with right leg proximal DVT and started on enoxaparin 2 weeks ago. He's planned for gastrectomy next week. So how would you manage him? So the first thing I did, I called up the surgeon and asked him, can we postpone the surgery? And he said if he had just partial response, he didn't have a very good response, there's a chance the tumor may grow, so we really need to do the surgery. So I find this table quite helpful. And Dr. Sarah mentioned to you guys that 4 to 6 weeks are the critical period. Even if he gets 4 weeks, I buy that and I can go ahead without inserting an IVC filter and just stopping it 12 hours before surgery. But this was like only 2 weeks. So we were really stuck in this patient. And if you see so he falls really in the very high risk group for of anticoagulation recurrence. So we did was continuing enoxaparin and stopped 12 hours prior to surgery. We got an IVC filter inserted post-surgery by 6 hours. Prophylactic dose was allowed by the surgeon, so we started that, and after 24 hours, therapeutic dose was resumed. I tend to remove the IVC filters at least after 4 weeks of anticoagulation, sometimes even beyond that. Upon discharge, no medical white heparin was switched to apixaban, and just they did total gastrectomy, so there was no more site of bleeding. So that's how we manage that patient. And what I learned was basically cancer patients that are at increased risk of thrombosis and bleeding. Use of IVC filter is indicated. Use IVC filter in indicated cases. It doesn't save lives, but sometimes it's really indicated. And always remember to remove filters if if not indicated and patient not on palliative therapy. One of our chairs, Dr. Abdurrahman Raiza, showed that around rate of removal in some of the centers around 75%. So actually there are 25% of filters left in and missed, actually, not only left in because we want to leave them, they're missed. So always have a protocol in your center not to leave filters in if not indicated. And with that, I end my talk, and thank you for listening.